All right, can you see my screen
Yes.
and see the arrow and so forth? All right, great.
Yeah.
So just like on Tuesday, first of all, thanks for coming back for part two. And if you have any questions, just like on Tuesday, please just blurt them out or put them in the chat, and I will do my best to answer them. So I'm going to start off with a bit of review to make sure that we're all on the same page, because while I'm certain that everybody remembers everything I said from Tuesday, we should probably start off with a bit of a review here. So let's, so remember our motivation was that trying to stress just how different each of these patients are. And so I started off with this story about in the 1940s when people in the US were trying to design cockpits for the first generation of fighter aircraft, and they were having all of these accidents, and it wasn't an engineering problem, it was a pilot discomfort thing. So they measured these different dimensions of anatomy on the patients and figured, on the pilots, and found what the average of this 10-dimensional space was that was really important, plus or minus 30%, and there were still no pilots of those 4,000 that fit into that 10-dimensional space. And then they started adding adjustable things within the cockpit. In fact, I'm told, I'm obviously not an expert in this, I've read that this was actually the start of the adjustable things in your car seat. Before that it was one size fits all, and now they started to make them more adjustable to people. And the person who led the study had this quote. He said, if you design the cockpit to fit the average pilot, you're really designing it to fit no one. And then I used that as a lead into this issue with clinical trials. You can use it to identify the intervention that works best for the population average, but there's no average person. So if you find the therapeutic regimen that works best for the average patient, you're really finding the one that works best for no one. Then I put this disclaimer on this, and of course, statistical inference is enormously powerful, but it does rely on properties of large populations. So if you're trying to do something that has tremendous heterogeneity in it, like treating cancer patients, you gotta be concerned with the individual patient's characteristics rather than what the population is telling you. These high consequence decisions have to be based on more than just data analytics. So we're going to discuss how we use the knowledge from Tuesday to work towards optimizing interventions on a patient specific basis. And so we'll start off with some review for Tuesday, and then we'll go into how this can help us build digital twins and talk about the importance of assimilating data as it becomes more, as more and more becomes available, and then trying to throw optimal control theory at it to find optimal interventions, right? So the two main things, or here, let me blank this out for a second. Remember, on Tuesday, we talked about a whole lot of patient-specific imaging data. We had the high-resolution MR and CT that let us set the computational domain, was useful for segmenting tissues, for registering images across time, those things. And then we moved on to functional characteristics, sort of at the physiological, cellular, and biological level. So we looked at contrast-enhanced MRI for blood flow, vessel permeability. We looked at diffusion MRI for cell density. Then there was FDG PET for glucose metabolism. And then we also looked at some cell surface receptor imaging from PET. So those are kind of the tools at our disposal that we can use to calibrate these math models. There are satellites or weather balloons from meteorology.
Don't show up.
Yeah, I was blanking it there so that I could just have your attention. But here we go. Yep. So here, just to review two of them, the dynamic contrast enhanced MRI. This is the serial acquisition of images before and after the injection of a contrast agent. And so if you look right here, that invasive ductal carcinoma lights up when the contrast agent is injected. That gives you a time course, a signal intensity time course that you can then analyze with a pharmacokinetic model. And we showed how you can analyze each pixel in these images to get a map, in this case, of vessel perfusion. And the reds indicate high perfusion, the blues and yellows are lower. And you can use this to estimate who's going to respond and who's not with an area under the ROC curve of 0.77. So this is all review from Tuesday. One more bit of review. The diffusion stuff, water diffuses with some sort of characteristic time constant. If you imagine in your mind's eye a pixel that's filled with these cells, then water can only diffuse so far per unit time. But if you give a cytotoxic therapy and some of these cells die in lyse, there's more extracellular space. And so water can diffuse more freely per unit time, and the diffusion distribution will shift to higher values. And so people have used that to map the values in vivo. And you can see that when you have a positive treatment, the values go from the low values, meaning low diffusion, which means high cellularity, over here to regions that have high diffusion, which means low cellularity or positive response. And when you get that, you get an area under the curve of 0.81. So those two measurements, when you combine them, give an area under the ROC curve of 0.88 for separating responders from non-responders. And that gave us the motivation for using them in mechanism-based models. The metaphor was that, just like in weather modeling, we have global maps of humidity and pressure gradients and temperature gradients and wind velocities, and those go into a weather model to make a weather forecast. Those things that we talked about on Tuesday and just reviewed a few moments ago, for example, vessel perfusion and cell density, go into a tumor model to make a tumor forecast. Then we reviewed where those models come from. So we have exponential growth, which works for cells in a dish, and even tumors on a hind limb of a mouse for early time points, but then they grow up to a carrying capacity. There's only so many cells per unit space that a petri dish or even a mouse's hind limb can support. Then we talked about incorporating a spatial variation. That's this diffusion term right here. And I made the comment that, early on when we use this model to calibrate data and then predict forward, the tumors were growing much larger than what we saw in vivo. And so then we took that tumor diffusion coefficient there and damped it to the von Mises stress when we get from solving this differential equation that involves the divergence of the Cauchy stress tensor. So that was all review. We tied it to this treatment term right over here. So we had movement, proliferation, treatment, and then we used this little video to try to show what was going on. These are the data on the bottom row right here. We're trying to predict using these two first time points to calibrate this model and then predict forward to how that third one goes. So we have data that tells us about the drug delivery. That's the contrast enhanced stuff. We have our cell density here that we're trying to match. And the idea is, how does this compare to that value there? And here was a summary of 139 patients of measured cell counts versus predicted. The size and shape looks pretty good. Area under the curve is 0.89 with this patient-specific mechanism-based model. Mechanism in the sense that it incorporates how the tumor cells are migrating, how they're responding to treatment, how they're proliferating, and the surrounding mechanical properties of the tissue. So we feel like we're getting good at that. We talked about the details of these things. This was the data itself, the multiparametric MRI. There was the pre-processing component, the registration, the segmentation, both within a visit and then between visits to yield us those cellularity maps that then went into the model. We talked about generalizability. So this was with the data that came from 10 different disease sites, 10 different clinical trial sites across the country. It's part of the I-SPY2 data set. And we still have these really high correlation coefficients from predicted versus measured. And this was a really, a nice result because it's from 10 different centers with 10 different ways of, potentially 10 different scanners with all the little idiosyncrasies that they might have. And then we looked at brain cancer, a new result from cervical cancer, and then prostate cancers as well. All right, so that 10 minutes was all review from Tuesday. So now I'm going to slow down a little bit because hopefully now you have fresh in your brain all the types of measurement that we're using and then how we use that to calibrate the models to make predictions. This is a good time to say, are we all on the same page? Any questions or comments? Maybe a thumbs up or a thumbs down if that's how you're feeling. All right, thank you, Amy. I can always count on Amy for giving me a thumbs up, so thank you. All right. All right, so if you get nothing else out of this presentation, I would encourage you to look up this paper. I had nothing to do with it. This is by Karen Wilcox, who's actually, or led by Karen Wilcox, who is actually the director of the Odin Institute for Computational Engineering and Sciences, where I have an appointment at UT Austin. And so she's an aeronautical engineer. And a few years ago, they published this really nice description that's basically a mathematical abstraction of a digital twin and its associated physical asset. So they're aeronautical engineers, so they have these things, that they call assets, whether it's a plane or a drone or whatever. We don't typically refer to patients as assets. We refer to them as patients, but the idea is the same. And so there's 6 components. 3 of them are associated with the physical asset, and they can be, you can touch and feel and measure. They exist in the real world in some sense. So you have the control inputs. These are the things you can do to the system. For them, it's things like in-flight maneuvers or maintenance or sensor installation. You can do that to the system you're looking at. There's the actual system itself, the physical state, is there a crack in the wing? What's its thickness? That's that kind of thing. Things you can, the actual object itself. Then there's the measurements you can make on the system. That's your observational data. So measured strain or accelerometer data, even flight logs, those kinds of things. These 3 things all exist in the physical world. Then there is the digital component of this, the digital asset here in red. You have your digital state. This is the geometry, the structural parameters, the boundary conditions. There's the reward, the thing you're trying to maximize, For them, it might be overall performance, mission success. Did the Amazon drone deliver your new pair of shoes in time? You know, that kind of stuff. How much fuel was burned in the operation? And then there's the quantities of interest that you track to try to maximize your reward. So for them, it's stuff like stress, strain, displacement, etc. So this set of 6 different objects, 3 in the physical world, 3 in the digital, is a really powerful way to attack problems in oncology. At least we think it is. So here's the oncological version of that. So here's a digital twin for predicting and even optimizing treatment response. So a patient presents, they have their physical state, call it S sub I. We're indexing it here on I, right? Because this is an iterative process, right? The patient just has to come in and get treated and then turn them on their way. They get treated and then there's follow-up measurements, and it's a cyclical iterative process. So the patient presents with their physical state that exists in the real world with their own anatomy, physiology, their tissue has certain mechanical properties, etc. Then there's the measurements you can make on the patient. You know, I grew up in imaging science, and so we do a lot of imaging work, but of course this could be genomic data, it could be anything that you, histological data, pathological data, anything, clinical data, any patient reports, any kind of thing that would give you reasonable data. So for us, we measure, like we talked about on Tuesday, anatomical stuff, perfusion data, permeability, cell density, metabolism, all those measurements we talked about on Tuesday. Again, this is happening in the real world, how you're observing your physical system. Then there's things you can do to the system. You can order more additional studies. You can order follow-up biopsies. You can try to change the treatment. These are things you can do to the system. So that these 3 all exist in the real world. Then there's the corresponding digital components right here. So this is your computational domain, which we get by segmenting our anatomical images. There's the finite element mesh or the finite difference mesh, whatever it is that your finite difference grid, whatever it is that you're using, that's going to let you solve your equations on the domain. Of course, your boundary conditions are super important. And then your parameters, you know, what's going on? What are you tracking in the tumor? Is it just size and shape, or are there other things that are going on? The tissue mechanics might be important. The input to the system, the treatment regimens. And so this one is especially exciting, I think, for us today. So I want to point out this left-hand column right here, right? So, well, first I'll start over here. So this right here, the skeleton right here, these are the major vessels of this woman's breast, and this sort of magenta thing here is the tumor, right? You can see that this vessel in particular is feeding it rather aggressively. All right, and so this is a distribution of the drug throughout the breast. And so the idea is we know a priori that the therapeutic regimen, that we give in the standard of care setting for each patient is not the optimal one for that patient. We get these from the phase 1 clinical trials, what the therapeutic dose should be. It's called the maximum tolerated dose. So that's figured out in phase 1 trials, then that's moved on to phase 2 and 3. And if it's efficacious, then you move for approval and make it part of the standard of care. But everybody knows that therapeutic regimen you get from the phase 1 trials is the one that works best on average for the average patient. It's that second slide that I showed you about the problem with clinical trials. There is not enough patients or resources to try all the different ways you might want to give that therapeutic regimen. In fact, it's even worse than that, right? Because most patients don't get just one drug. They get many drugs. So how do you order them? How do you schedule them? If you have to test that experimentally, it will never happen. You have to have a mathematical model that describes this. So, you know, once the stuff we talked about Tuesday gets a little bit further, we can then go on the computer and try things out. So this top row of this left column over here, the vertical axis is the concentration of drug, horizontal is time. And so this is a standard treatment for triple negative breast cancer. They get these 2 drugs first called adriamycin and Cytoxan, and you get 1 big bolus of it. And then there's 3 weeks during the refractory period where nothing happens, and then you give the next dose, right? So everybody knows that that is not the best way to do it for everybody. But unless you can experimentally test all that stuff, you'll never be able to move past this big bolus with a refractory period. It may be that some patients are better getting 1/3 of the dose every week, once a week for 3 weeks, and then repeating. You can think about going to the other extreme like we do in radiation therapy, where patients go in 5 days a week, and that's what this is indicating here at the bottom right here. This is logistically impossible for infusion centers. You can't have all the patients coming in every day, but it's just one extreme, a large bolus, 20 days refractory period, all the way to the other extreme, 1/21st of the dose every day for 3 weeks. If you have a mathematical model that describes how these tumors are growing and responding spatially and temporally, and it's giving accurate predictions, then you can start using that model to optimize the intervention. And that's where this field is going. So I want to pause there and see if there's a comment or a question about that, because that's a take-home point. Any comments or questions? All right. Well, if anything pops up, please just say something. All right. So here are our quantities of interest. For example, distribution of therapy, tumor shape, and cell density. And these two rows here correspond to one treatment regimen A and one treatment regimen B. And one is 1 dose and one is 3 doses. So this guy here, this bottom one where I'm pointing to, corresponds to this one up here, 1 bolus and then nothing for 20 days. And this has 3 doses, so once a week for 3 weeks. And you can see the color here indicates the intensity of the drug. And so there's more time points up here where this drug, sorry, where this tumor is orange and red, indicating a higher concentration of the drug is sitting there, as opposed to the 1 dose, and then it goes away rapidly. And actually, this leads to about an additional 60% reduction in tumor size, giving the same drug just with a different schedule. And then the idea is that you want to come up with some metric that balances efficacy with toxicity. So here's dose and here's schedule, and this is the surface plot for one patient. The outcome on the vertical axis, I've trimmed this down just to make it more visible here. It's actually a balance of toxicity and efficacy of the drug. So this is the surface that you get for different doses and schedules. So if you have a mechanism-based mathematical model, you can formulate this surface on an individual patient basis and find out where the optimal regimen is that optimally balances efficacy with toxicity. And what we find out in a lot of patients, not all of them, but a lot of them, the dose that they actually received right here is far away from where we would predict their optimal regimen would be. I want to dive down into that a little bit further. So just to review, patient comes in, they have some physical state, this yellow arrow here. We make some observations. This lets us build our digital state. We then are going to try to track and optimize our quantities of interest to optimize our reward, in this case, things like treatment response, overall survival, progression-free survival, those types of things. And then, of course, the whole thing iterates. After you assess your reward, you might change how you're assessing the system. You might take more measurements, or you might alternate the treatment, and then it all cycles back around. I want to drill down on this one a little bit more. So this plot right here, this is one of those plots that took us like 10 years to make, right? We had to first figure out the mathematics to describe how these tumors grow in space and time. Then we had to show that these predictions were accurate in many different disease settings, many different patient data sets, so that we could build confidence in it. And then we can go on the computer and try different things. So you see here, this is one drug, Taxol, and this is 2 drugs, adriamycin and Cytoxan. They're given at the same time for this particular type of cancer. And once you have this mathematical model, like the things we talked about on Tuesday and reviewed this morning, you can go on the computer and you can try different therapeutic regimens. Maybe the duration for adriamycin should only be over the course of 60 days. Maybe it should be stretched out over 80, similarly for Taxol. So this is the same total amount of drug, just given in a different way. And that lets you make this surface. Each grid point on this surface is a different combination of the duration of this drug and the duration of that drug. I hope you can see this gray horizontal line. Can you, plane? Sometimes this doesn't project very well. Can you see this gray horizontal plane? I just get a shout out or a thumbs up or something indicating that you can see this. Okay, great. Thanks, Amy. Right. So, whoops. What happened? What just happened? Here we go. Okay. Very good. We're good.
Yeah.
Okay. Great. All right. So this horizontal plane, everything above this horizontal plane, we would predict that the patient would have residual disease, and everything below it, we would predict that the patient had a pathological complete response. There was no residual tumor left at the time of surgery. This black dot up here is a therapeutic regimen the patient actually received. These teal dots are other options the patient could have received. There are, because it's standards, plural, standards of care. There are multiple ways that the drug could be delivered. And so for these 3 guys right here, we would predict that the patient would have had a complete response as opposed to what they had. So when we first started seeing these, they send shivers up your spine, right? Because this means that we left stuff on the table. There were options to treat this patient that were better than what we actually gave the patient. Now, of course, this is all in theory. This is theoretical, but it's not just this one-off patient. You can make these surface plots for each patient. And when we do this, we notice that without changing the total dose, just shortening or lengthening the duration, it changes the efficacy. And of 41 patients in this particular data sets that had residual disease, so they were non-pathological complete response, 41 of them, 26 of them, we were able to find a standard of care a dosing scheme that we predict the patients would have had a pathological complete response. That represents a 23% improvement in the PCR rate, not by changing the therapies or even the doses, just the scheduling of it. So this is like dipping our toes in and trying to do patient-specific scheduling. This is really tantalizing. And I want to emphasize that you cannot do this with an AI and big data approach. You can't do it for two reasons, both of which are enormous. One, to be able to do this with an AI and big data approach, you would have to have already run the experiments, the clinical trials that give you every grid point on here. You would already have had to have tried all these different combinations of therapeutic regimens to build this surface plot. And of course, there's not enough time, money, or patience to do that. The other big thing, of course, is it's even worse than that, because this surface plot is patient specific. It's generated given the characteristics of the individual patient. And of course, you can't do that with an AI or big data approach. It's all predicated on trying to find the patterns in the population. You have got to have a mechanism-based model to do this kind of thing. All right, so here's the details on how this might, a few more details, just like we had the details for how we can use our imaging data to the pre-processing and the registration and all that to get ready to be calibrated to a model to make a prediction. This is what we are doing here for trying to optimize treatment response. So we're going to shift to brain cancer just merely because this is the flow chart I had prepared. All right, so here's the treatment and imaging. For glioma patients, they get imaged a lot more frequently, sometimes as frequently as weekly. So each time the patient gets registered, we have to, or it gets imaged, that new data set has to be registered to the previous one. So when we talked about registration and segmentation before as a 1 or 2 off thing, this is now happening weekly, right? And so once you do that, you do all the pre-processing, get your cellularity maps and so forth, now you can drive this into a model. And here for the brain tumor model, we have something that models the enhancing region differently than the non-enhancing region, the blue thing right out here. So we have a system of 2 PDEs that we use to calibrate that model and then makes predictions. So those are our calibrated predictions. And you can see that there's different regions here that are predicted to be hotter or colder, meaning proliferating more or less as time goes on. So what we can do is we can predict the areas that are going to have the highest areas of proliferation. That's this green bit right here. And so we're predicting those areas have high proliferation going forward. And now that you can predict that, the idea is, okay, well, let's target that with the subsequent radiation therapies. So the radiation dose plan. So here's the standard dose plan that this patient would get. It's unfortunately, I'm sorry, I've oriented it the wrong way, but you can see that this region right here, this brighter region right here, is going to correspond to this region right here. And this less blue region over here, less dose, is going to correspond to this region over here. So the idea is you take this dose plan, which is the standard of care for this patient, and augment it by hitting a higher dose to these regions that you've identified as proliferative. So that you combine these two things, and this is the dose map you're going to give. And then this is, we give this dose map to our medical physicist colleagues, which is kind of interesting because it's actually a guy I went to graduate school with 1 million years ago. And it's fun how that played out. So this is for the graduate students out there, stay close friends with your colleagues. You never know when you're going to end up working with them again. So we send it to TJ Whitaker, my buddy TJ, and then they make sure that this is actually implementable. And of course, we have these things on a voxel by voxel basis, and that is not that's not realizable given the current say the art in radiation dose physics. But it's pretty good. It's blurred out a little bit, but you can see that this dosing scheme is quite similar to this one. So the question becomes now is, if you give this more optimized dose to this patient, how does it compare to the standard dose? Before we do that, let's make sure we got everything. So panel A here, this is high-grade glioma patients undergoing chemoradiation based on their MRI on a weekly basis. Panels B and C, this is our 2-species PDE model used to characterize the spatiotemporal development of glioma tumors. So this is completely analogous to what we talked about on the Tuesday and what I reviewed this morning about taking patient-specific imaging data to calibrate a predictive model of how the patient's tumor is going to grow. And then item D here, this is cellularity at baseline. And then at week 3, you use your model or whatever method you want to figure out where the areas of high proliferation are going to be. And then we try to target those by boosting the radiation dose to those areas right there. And so when you do that, where's my picture here? This is the standard of care radiation dose plan. So this is the standard of care radiation dose plan right here. And then this is cell density over time. So this is where we are after 2 months. And this is with our radiation dose plan boosted to the highly proliferative areas. So you have to look at this closely. Well, I don't know, somewhat closely. You can convince yourself that this region is now gone and this whole thing right here is smaller. But you can also see that it looks like we let this part get away from us a little bit. We've managed to control some of this stuff down here because there's not as many green and yellow pixels here. So that control has been better. But this area right here looks like we should have done a better job of boosting there. When you average, this is just one slight right of the whole volume. When you do this over the whole volume for the patient, you get, on the order of an extra 45% reduction in total tumor burden right here. So this is the standard of care radiation dose plan, which would be this one right here. And if we give this dose plan targeting the highly proliferative areas, we get this plan right here. And there's still areas to improve this. I mean, this is just a couple of weeks old when we sorted this out. So we're real excited about this. And this is where the field is going. People are trying to do this kind of thing. So you can see that there's this nice reduction in tumor burden from the standard of care to the personalized plan. So again, that personalized plan relies on taking personalized patient-specific imaging data, and then using that to calibrate the predictive model with a mechanism underneath the hood. Once you have the mechanism underneath the hood, then you can go on the computer and try different interventions, which is exactly what this is, trying a different radiation dose plan, this one versus this one. And interestingly, many radiation oncologists are willing to try different radiation dose plans if they knew where to do the additional dose boost. So this is a way to guide them on where to do the dose boost. It's also because they're willing to try things because the outcome for this disease is just so abysmal. High-grade glioma, glioblastoma multiforme, the most common high-grade glioma has a life expectancy of 12 to 15 months after diagnosis. So it's really a horrible disease, right? So we have to test this because, right, all of that stuff is in the sort of the theoretical realm. We're using a mathematical model that has very high predictive accuracy. So we have a fair amount of confidence in it, but we do have to test it. So this is a good stop. Questions or comments from anybody? Okay. All right. So we're trying to move towards testing this in the preclinical setting. So this is in the murine mouse setting. So this is in HER2 positive breast cancer. These are breast cancers that are overexpressing the human epidermal growth factor receptor type 2. And these patients, or these mice, as the patients, get a targeted therapy called trastuzumab. It's also called Herceptin, so it's targeted to the HER2 receptor, and then a broad spectrum chemotherapy, doxorubicin. So we did this whole thing, right? We developed a framework for model development, calibration, selecting the optimal model, and then through optimal, or the digital twin to try to find the optimal intervention. So this resulted, we're trying to do two things. One is to identify a therapeutic regimen that's going to result in greater and earlier tumor control. So we had 6 different treatment plans, 6 different groups, and this magenta curve is the one that had the best response. So you can see this is time in days. Tumor volume is allowed to grow up to about 300 cubic millimeters, and then we start the treatment, and this treatment plan had this type of tumor control. So we have 6 different treatment groups, and I'll walk you through the model in a little bit, but I wanted to give you the punchline so we can see the forest before we go through the trees. We have our model, we calibrate it, and we use optimal control theory to find the optimal intervention, and we can find, using the same dose, just different scheduling, that's going to lead to earlier and better tumor control. So that's one way to do it. The other way to do it is say, you know what, we're kind of happy with this tumor control right here. It's taking a little bit longer, but it's happening. So let's see if we can have the same level of tumor control with using less of this broad spectrum chemotherapy right here, because that's going to result in a lot less side effects. right? And so we found one that used about half, whatever this is, 43% of the total dose, that had the same tumor control. It's the green right here. So using this mathematical model that we can use to make these predictions that are accurate, and then throwing optimal control theory at it, we can have two different ways of proceeding, and they are readily testable. This method arrived on a therapeutic schedule that gave earlier and better tumor control, and this method gave same tumor control, but using half the broad spectrum chemotherapy. And so these are readily testable hypotheses. All right, so now one last bit here of updating the measurements, and then we'll come back and finish it off with some of the details of that previous slide we just talked about. Okay, so data assimilation is a set of techniques. Actually grew up in weather modeling. I told you, I think on Tuesday, how this whole bit of imaging-based mathematical modeling kind of germinated when I was reading a review of meteorology. So always been very interested in this, and we just slowly are stealing ideas from them. So here's data assimilation, is a set of techniques in which newly available data are integrated with the predictions of your model to refine the characterization of whatever system it is that you're looking at, right? So here's how this sort of plays out, right? You fit a training group globally for some population average. So you can start from before you do your intervention, you're going to make a prediction of how this particular mouse or person is going to respond to some therapeutic regimen, and the population parameters you get from your model, the parameters you get from your model to make a prediction about this individual comes from the population. So, and the individual's initial conditions. You get the initial conditions from the individual mouse or patient, but the model parameters come from the population because you only have the initial conditions from the patient, and so you can't calibrate the model yet. So then you measure up to some sample time points, call it A times your delta T. You make a measurement there, and now we have two measurements for the patient or mouse or rat or whatever that we can calibrate our model for to give our patient-specific parameters. But maybe you don't want to chuck away all the population data, so then you slowly start to you average the population parameters along with the individuals parameters, and as you get more and more individual data, you care less and less about the population. So you'll be averaging the patient-specific parameters along with the population parameters, but as you get more patient data, you weight the population data less and less, right? And so that's what this scheme is trying to tell you. Initially, you predict with the initial conditions of the mouse or patient and the population-based parameters. You get your second time point on the individual. You can then update your model parameters, weighting the individual parameters more than the population. And as you go on and on, you get care less and less about the population. So here's an example of this. These are cells growing in a dish. So this is where we started this. And you get lots of data points for cells in a dish using time-resolved microscopy. This is 300 days. This is actually a little over 300. This is like 2 weeks, basically. And here, this green line, this is what we get from if we just take the initial conditions of this Petri dish here, use the population parameters to predict forward, this is the prediction you get. And you can see that it's good at early time points, and then it kind of flies off the handle here. It doesn't match the individuals anymore. But if you update it, in this case, might be every day was what we did here, then you can stay with the data, and it looks like at the end here, it's time for another update because it's indicating that this is still going up, and it looks like it's leveling off in reality. So this notion of updating your model as time goes on is kind of natural and very effective. Here is a bunch of cases with two different types of cell lines to show the same thing. The green line is, what we get if we just take the initial conditions for the Petri dish, along with the population-based parameters and make a prediction. And you can see sometimes it does a pretty good job. Other times, not so good. Sometimes really bad. Sometimes really, really bad. So this notion of trying to take the patient-specific data and update your model as you go in time, and that's the magenta curve here, is doing a much better job. It's not really surprising, right? But this is an important concept to consider for the data assimilation. So that's moving from Petri dishes, where we average the cell numbers over the whole dish, to now trying to do spatial variations as well. So on the top row here is our prediction for how these cells are going to grow within the whole Petri dish, as opposed to what's actually observed over 792 hours. So this is several weeks now. And you can see that early on there's the seeding is pretty uniform, but then you start to have these hot spots appear, and our little model can start to capture this and make predictions of it. So and as you update the model over time, you can keep track with the predictions for what's actually measured, right? And then, of course, after you get confidence with this, you can start to do this in humans. And so here is the glioma version, right? So just to make sure we're on the same page, we had these well plates. We did time resolved microscopy. First thing we did was just average the cell numbers over each well plate to try to be able to predict using data assimilation how those time courses of cell number are growing over time. Then the next slide was about looking at the spatial variation over the whole well plate, getting confidence with the technique, and then we go into the patient data here. So again, this is high-grade glioma. Visit 0 and visit 1, you can calibrate to make your first prediction, and then when they come in for their next visit, you now can recalibrate the model to make a new prediction, and they come in, for the teeth visit, and then you can calibrate over the whole range to keep making a prediction. And here is the measurement over time, and here's the prediction over time. And if you look at this, you can see that our predictions are doing pretty good with tracking where the areas of high cellularity, the reds, and the areas of low cellularity, the blue. But if you look a little bit closer, you can see that, of course, our model is not perfect, and we're kind of playing catch up. So if you look at, say, this prediction right here, you can see that this one more closely matches the week before. We need our model to be able to nail the present week, the next week, just as well as the previous week here. So there are things missing from this model, which unfortunately we don't know what they are at this time, but actively trying to investigate that. So on the whole, it does a pretty good job of finding the areas of high cellularity and low cellularity, and even where those regions are, but the match is not perfect because the model, of course, is not perfect. Any comments or questions? Amy, are you still there? I'm always relying on you, Amy, for a response, a thumbs up or something.
I'm still here.
Yes, Amy's still there. Yes. All right, we still have Amy. Okay. Then I go over here and go back to here. All right, so this is back to our optimal control theory business. Here. All right, so optimal control theory aims to determine the specific factors controlling a system so that the specific criteria can be achieved. So for us, maybe how to maximize tumor control while minimizing side effects. These are the two things you want to optimize. Of course, you can maximize tumor control by just ramping up the radiation or ramping up the systemic therapy, but you're going to do a ton of damage to the patient. So we have to figure out how to maximize one while minimizing the other, right? So here's a super duper fast introduction to optimal control theory, to OCT. So consider some dynamical system describing a growing tumor, and the rate of change of the tumor size, tumor volume with respect to time, is some function of what the tumor is at whatever time you happen to be looking at, plus the treatment you're giving, that Z, and then the time you happen to be looking at. So we've seen lots of examples on Tuesday and today of different mathematical models, and this is just formally a description of what a mathematical model might include, right? All right, so our basic objective is to identify a treatment plan, Z of T. This is the guy that we can play with, Z of T, such that T of T is minimized at the final time, T sub F. So this is the point I've tried to make today, in that if you have a mathematical model that can describe how a tumor is describing in space and time, and you have confidence in it, and it's giving good predictions, then you can go to this kind of thing and go on the computer and say, okay, I got this model, and it's calibrated with the patient-specific information, and I've got confidence that it can do a good prediction of how the tumor is growing in space and time. Now I can go and try to optimize the intervention Z right here. So this is exactly what we need to do next. This is a repeat of what's on the previous slide, just to keep it in front of us. Also, because I know you're going to go back and study these slides. When you're flipping through the slides, I don't want you to have to be bothered with flipping back to the previous slide. You got it right here. Okay. So in the language of optimal control theory, T of T is the state variable that describes whatever important features of the system you are having. It could be tumor volume, it could be tumor cellularity, which is what what our team has always done and what we've talked about on Tuesday and Thursday. That's that N of X comma T that we've seen there. That could be the important thing. It could also be, metabolism or proliferation or whatever it is that you think is important about your tumor. That's your state variable. And then Z of T is your control variable that affects that state variable by acting on it. And so you do this by defining an objective function, call it J, where the goal is to adjust the control variable, that is that Z, to minimize or maximize J. So this is the exact same thing you might have when you're trying to fit a curve model to data, calibrate a model to a data. You have a cost function, chi-squared, the sum of the squared differences between the data and the model, and you need to minimize that by changing the parameters in your model. And the parameters that let you minimize that cost function are the parameters that you say describe the system, right? Same idea here. We are going to describe some cost function, some objective function, and we're going to adjust the Z, that's the Z of t that is analogous to the parameters in the description I just gave of fitting a curve to data. We're going to adjust the Z to minimize that J in the same way that you adjust the parameters to fit your model, to fit your data rather. Okay, so the J consists, there are many ways to phrase J. One that's commonly done is to adjust it consists of a term that tells you about the endpoint costs, the tumor reduction, the main thing, your quantity of interest that you care about. How much has the tumor been reduced? How much has the cellularity been reduced? How much has the proliferation been reduced? Whatever it is at the endpoint, at that T sub F. But what happened along the way is also important. So you have to have this term they call the integrand, and there's an integral there that's sort of tallying up how much drug that you're giving. And that's a good way to control the toxicity, or at least get your hands around what the toxicity is. So trying to get an application of this. But this is, keep this notion in your head here. We're gonna make this one specific after I introduce the application that we're gonna use it on. So our J, our cost function, is gonna have a term that that's gonna track how big the tumor is at the end of the treatment, along with an integrand that's gonna be tracking how much drug you're giving along the way, right? Okay, so just like you saw before, we treated those HER2 best tumors in the mice with Herceptin and doxorubicin. This is back to those curves that had the magenta curve in it, and I said there's two things we can test here. One is trying to get earlier and better tumor control, and the other one is trying to reduce the amount of chemotherapy we give. Those are now readily testable. And I said we're going to give you the punchline. We're going to look at the forest before I go through the trees. So that was the forest. Now we're going through the trees. So we showed Herceptin prior to doxorubicin. With half the doxorubicin, improved overall tumor control. So these are the 6 different groups we had. You know, group 1 is just the control, so they just get saline. Group 2 is doxorubicin first, followed by Herceptin, which actually did no better than group 1 here. It did no better than it because these tumors are HER2 positive, and this broad spectrum chemotherapy doesn't do a whole lot. Herceptin on its own did pretty good. The one that did worse, actually, was doxorubicin first, then followed by the Herceptin. And that was because the doxorubicin is this broad spectrum chemotherapy. So it's killing lots of cells, including the endothelial cells that line the blood vessels, which are the pipes that allow for the subsequent delivery of Herceptin. So if you're killing off the delivery system, you can't get the Herceptin there in the first place. So that was an interesting observation. And then this one right here is when we give them simultaneously for group 6, right? So the modeling OCT goals was to develop a model that captures the overall treatment efficacy of all these different ways of intervening. So you want a model that when you put in the different therapeutic regimens, you get the output that matches what the mice in that group actually did. And you want to do that for all 6 groups, right? And then once you have a model that can do that, you have confidence in its ability to describe the system, you apply optimal control theory to find the most efficient treatment protocol. All right, so here's just a repeat of that business right there. Here's our model. It's actually not that terrible right here. So we have a term here, the rate of change of phi sub t, which is the tumor volume, right? So that's our thing. What, is there a question, comment? Did I hear something? I don't know, maybe someone sneezed or something. Just make sure there's nothing in the chat here. All right. So we have these are cells on the hind limb of a mouse. So are you going with the ODE approach? So we have the rate of change of the tumor volume right here. This is the thing we want to control at the end. And basically it has logistic growth. So if you distribute this R, this growth to this term, you got R on phi sub t times the logistic term here, K is the carrying capacity. But then you're also going to strip off some of that proliferation due to the efficacy of the Herceptin, and then the efficacy of the doxorubicin and Herceptin acting together. And then there's the rate of change, there's the rate of change of the amount of Herceptin and the rate of change of the amount of doxorubicin, the broad spectrum chemotherapy. And basically you have a delivery term and then a way that it's being eliminated from the system. Herceptin's efficacy wanes exponentially, so we have a delivery term and then how it's being eliminated from the system. So it's actually a pretty simple model, and we have 6 different groups, and we have multiple time point measurements for the volume for each one of these groups. So there's a fair amount of data, so we can calibrate this model.
So Tom?
Yes.
Tom, can I ask you a question? And in the first equation, you multiply the treatment terms with the logistic term 1 minus phi t over k.
Yeah.
Okay, can you explain why you do this?
The growth term, because the tumors, when we put them on the hind limb of a mouse, they will grow exponentially at early time points, but then they reach a carrying capacity and they will no longer grow exponentially. So the logistic fit better. I actually left out a whole chunk of this because this wasn't the first model we wrote down. We wrote down like 20 some odd models and then did a model selection. And this is the one that won. So the tumors grow.
This was, yes, sorry, this was not my question.
Sorry,
my question is,
sorry.
If the population has a carrying capacity, then the treatment is ineffective, right? And then the phi h doesn't do anything.
Oh, right. Yeah. So this is, yes. So you're saying, why is the treatment term logistic as well?
Right. Yeah.
Okay. Yeah. So that's a very interesting point, and we wrestled this with a whole lot. We wrestled this. We wrestled with this a whole lot. We ended up just trusting the the Akaike information criteria for picking this model as the one that bet it. So that described the data the best. So we went with we just trusted the model selection, but you're right, the interpretation of it is a bit bizarre because you can imagine growing logistically, but now you're treating and you're kind of going down that same path. So that's a little bit confusing. Perhaps it's more natural, and we looked at this one, was to have logistic growth, but then have the treatment terms as separate. So you just have lambda sub h times phi sub h times phi sub t, over here away from the logistic term. But that did not do as good a job as describing the data.
Interesting.
Yeah,
okay.
I don't, interesting is a nice way of describing it. It's interesting, but really, Tom, is that really the right way to do it? And I don't know. And this actually brings up a much bigger point. And that all of these models that we're using are phenomenological, right? It's not like they're handed down from on high. It's not like they're derived from conservation of energy or momentum or things that we hold near and dear. We have observations that we make, and we try to write down the most parsimonious model that describes them. So that's always lurking in the background and causes me to lose sleep. You can derive the reaction diffusion equation from first principles, but that's not what this is. This is just saying, okay, there's a proliferation term. We notice that they grow logistically. Let's put that in there. Okay, it looks like these we give a dose of these 2 drugs, so we got to have a source term, and it appears that the efficacy of Herceptin wanes over a period of time, so we'll exponentially damp that delivery term, and then they're removed with some rate constant, tau sub h, tau sub d. It's not like these are handed down from on high. These are just phenomenological models. So I hope that doesn't take the wind out of everybody's sails, but it is absolutely true. We do not have the F equals MA of cancer, but we are a heck of a lot closer than we were 10 years ago.
Yes. Okay. Thank you.
Yeah, thank you for bringing that up. It's an important point. Right. So we have this model. There was a whole host of models. Did model selection. This is the one that sort of won. So we took this, calibrated to each one of these data points for each group, and the calibrations are good. All right. So our modeling goal: develop a model that captures the efficacy of that combination. And here are the examples from the 6 groups right here. So the error bars are from all the animals that were in each one of these groups. But you can see that it does a pretty good job of capturing how these tumors are growing over time, regardless of which therapeutic intervention they had. Right, whether it was the control with so that's just saline, doxine, doxorubicin only, no difference, right? Because it's HER2 positive breast cancer, you got to have this Herceptin, pretty good control here. Dox followed by Herceptin, the dox blasts the endothelial cells, so you don't have the pipes to deliver the subsequent targeted therapy. So this is actually statistically identical to this one, no difference there. If we didn't do the Herceptin first, we had actually the best control, and we found out we could only use half the docs to get this control here. And then if you give them simultaneously, you have pretty good control as well. Okay, so our model is calibrating the 6 different groups. And so now, to remind ourselves what we're doing here in the language of OCT, our T of T is our state variable that describes the important feature of the system. For us, that's tumor volume, the vertical axis on the 6 panels from the previous slide. And the thing we're trying to control for, the thing we're trying to vary to control that state variable is the Z of T, how you're giving the drug. So we do that by defining the objective function, where the goal is to adjust the control variable to maximize it. And remember, the J consists of our endpoint cost, the total tumor reduction, plus the integrand. That tracks how you're giving the drug over time. And so here is what it looks like. For our goal here, minimize the tumor volume by day 68. That there's technical reasons that are not interesting for why we picked 68, or rather experimental reasons why we picked 68. Minimize the tumor volume by day 68 and the amount of drug delivered. So our objective function looks like this. You're giving the doxorubicin. This is your source term for doxorubicin, the broad spectrum chemotherapy, and our source term for H. And so this is, we have some weight for the tumor volume at day 68, and then you have some weight for when you're giving the dose for the doxorubicin and the dose for the Herceptin. And so V sub T is the tumor volume, U sub I are the drugs that are delivered, and the W sub I are the weight. So these are the things that you can vary. You can systematically do this, right? So we used our digital twin, right? Our mathematical model that was in the bottom left-hand corner a few slides ago. And then we use that with the model parameters from the mice themselves. And then we throw this system, sorry, I shouldn't say throw. We try to optimize this, this objective function so that our tumor control is best. Earlier and greater and earlier tumor control. That was well, I shouldn't have said left panel right there because there's no panels here, but this was the left panel on that slide a few slides ago. And or equivalent control using less doxorubicin, that was the one on the right. And those are readily testable. Now, the big letdown's coming because what you're expecting on the next slide is the test of these two experiments. And indeed, we're about halfway through those experiments. So I debated whether or not even to show this because we don't have the answer yet. I can tell you that off the record, things are looking promising, that our hypotheses are being validated, that we've actually landed on a way to mathematically optimize the intervention to have better tumor control for these mice using an optimal control therapy approach. But I don't have, it hasn't been peer reviewed or submitted or anything like that. So I'm not gonna be able to deliver the punchline that you want to hear, but ask me in 6 months. So this is just a summary of this stuff. We use the digital twin optical control theory to try to identify a therapeutic regimen. And this blue one is the therapeutic regimen that we identified. So there's a Z of T that gives us this better and earlier tumor control that's now being tested, what I was just talking about. And we also found equivalent tumor control using half the doxorubicin. And so this green line is the prediction here. And so that's what's being tested now. Those are 2 readily testable hypotheses that we landed on from mathematical modeling. So I want to encourage you not to be completely disappointed that I can't show you the final results, right? Email me in 6 months and I'll tell you what the answer is. But what we've done here and what people are doing is kind of cool, right? Before, if you wanted to figure out what therapeutic regimen was going to be best to have tumor control in these mice, you'd have to run 1 million experiments to figure out what the dosing would have to be, as well as the order and timing. But with a small set of experiments, 6, basically it was control, each drug on its own, and then one drug before and after the other one, and then simultaneously, I think those were the 6. You calibrate your model, and then from there you can go and arrive at a therapeutic regimen that is hypothesized to outperform the ones you actually measured. And then you can go and test that because you have an explicit Z of T. You have an explicit therapeutic schedule to try to give these animals, and that's the experiment that is ongoing. Okay, so beware. There is some audience participation requirements coming up shortly. I really hope that you pop in for these because these are open questions that the field is really struggling with. All right. So I actually no longer think there's significant technical limitations to getting these digital twins into clinical application. But how are we going to actually do it? There are real logistical and well, we'll just leave it at logistical. There's logistical limitations for this. For example, how do you get physician and patient buy-in? How do you communicate the results of a digital twin prediction to a physician and have them be able to use it? How do you get patients to buy into the notion of a mathematical model to identifying the best way that they should be treated? You know, how do you even report it? How do you generate a digital twin report? You know, for imaging and pathology, there's path reports and there's imaging reports. The radiologist does a read, and there's an established system for how this is done. You know, what on earth does a digital twin report look like? And what is the low-hanging fruit that you could apply this to? What are the first use cases that will be most successful? I will say that there is some precedence for this at the population level. There's this thing called the I-SPY trial. I-SPY is this forced acronym that I don't remember. It has it's an adaptive clinical trial scheme. And what they actually do, it's for breast cancer. It's been going for about a decade, maybe a little more now. And rather than run trials sequentially, they start with roughly 10 at the same time. And yeah, right. So a patient comes in here, they have some set of characteristics, and those characteristics are used to match them on one of these 10 arms, right? They're randomized to either experimental or a control arm, which is the standard of care, based on what their characteristics are. So then those patients, they assess their PCR's pathological complete response, RCB is residual cancer burden. They assess these things to see whether or not the patients are doing well in those arms. And if they're doing well or poorly, you can update the predictive probabilities for how a patient coming in with those characteristics are going to do on that arm. So after you get enough patients into these arms, you can either advance them and say, these are the ones, this is the arm that's really working for patients with these characteristics, or you can shut them down because they're not working, they're futile. And then you update your probabilities. And so the next patient who comes in has, in principle, a higher likelihood of going on one of those arms to give them a better outcome. So this is an adaptive thing at the population level. Patient characteristics and outcomes are used to update how future patients are assigned to study arms. So that adaptive design seeks to move patients from arms less likely to help them to arms more likely to help them, and do this for the population as soon as possible. So you don't have to wait for the completion of one trial before starting the next one. So what people are doing who are trying to do this on a patient-specific basis is do this for the individual through prediction rather than the population through assessment. That wheel on the previous slide, you're updating the treatment regimen the patients are going to get at the population level based on how the previous population is going, which is fantastic. It has dramatically accelerated the way at which promising drugs are getting into the clinic for breast cancer patients. It's a real success story. So now the next goal is to go from doing this at the population level to the individual. So while I-SPY seeks to assess early in therapy which population would benefit from a particular treatment, the people who are trying to build these mathematical models, they're trying to predict early in therapy which individual would benefit from a particular treatment. All right, so now it's time for audience participation. What do you guys think are the answers to these things? How do you communicate this information to physicians and patients? How do you summarize all that's going on in forming a digital twin for something that's clinically of value? And what are the low-hanging fruit to go after first? I would love to know what people think about this, especially yeah.
Yeah, is there any sort of cost associated, or is there a benefit to doing this? So it might entice more people to do it.
Right. I think the cost to benefit in principle is very high, right? You have an individual that comes in and you say you have this set of characteristics. So people who previously have had these set of characteristics have worked historically better on this therapeutic regimen than this one. That's what we do now. But wouldn't it be better to come and say, well, you have these set of characteristics, and we know from your set of characteristics, this is the way to treat you. So I'm not referring to 10,000 of your closest acquaintances. So that is attractive. But how we've picked that therapeutic regimen for that individual is based on math. It's not based on running 57,000 clinical trials. And so that's yeah.
What about the turnaround? So say a patient comes into a physician and the physician puts the information into the model how long does the model take to come out with results? Or
Yeah, that's a fantastic question. Yeah, what's the turnaround time on this? So there's a whole bit of stuff I didn't talk about how to implement these on high performance computers to get the results back rapidly. Right now, for the largest tumors, which are going to have the largest domain that you have to solve your system on, it's about a 24-hour turnaround. There are we and others have come up with ways called underneath the heading of what's called reduced order modeling that can get that down, 10 or even 100 times faster. With acceptable limits in the error that it introduces, right? Because you're cutting corners in some sense. But so I think we can get the predictions back in a reasonable amount of time. Yeah, I think that's a tractable problem.
yeah, I'm in the UK, so obviously we have the NHS, and they're
Mhm.
very they don't do anything unless there's evidence and it's massively sort of worked through in terms of the costs it's going to be for the benefit and that sort of thing. Is it more likely that this sort of stuff is going to take off elsewhere where you've got people that perhaps have more ability to opt in financially or
Right, right.
choice?
Right. Well, Emma, I think the condition in the U.S. is very similar to what you just described. So, we have a group of close physicians, that clinical oncologists that we work with, and we're buddies, we're friends, we exchange pictures of our kids with each other. So we're all a tight knit group, and but when we go and we say that we want to now do a prospective trial where we're going to pit the standard of care therapeutic regimen against one that's going to be optimized on a patient-specific basis for the digital twin, a lot of the card-carrying practitioners are like, what? Slow down. I need at least one and preferably 3 phase 3 clinical trials before I'm going to change my therapeutic regimen for a patient. So we get that pushback a lot. And in fact, when I first had those meetings, I think it's one of only 2 times in my career that I actually physically cried about something that was happening professionally because I just felt like we had hit a brick wall. Like, what are we doing all this for if we have to end up running these very large clinical trials? So now, what we're trying to do is just dip our toes in the water. To us, our low-hanging fruit is in the radiation oncology for these high-grade gliomas, because there's such little to offer these patients anyway. So I think the barrier is lower. There's also, and this is just my own experiences, it's not based on data, the radiation oncologists that we work with, many of them came up through their training in the physical sciences. So the notion of using a model is not foreign to them. So I don't, that I can't generalize that, but that's the experience that we're having. So I think and radiation oncologists are also willing to change the dose map that's given to patients based on some knowledge of what's happening to the tumor. In fact, they do that already, but it's always in response to what has already exploded, right? You want to be able to predict the areas of explosion and target those early before they take off. So we think that our low-hanging fruit to go after is in the high-grade glioma situation. Yeah.
Well, thanks, Tom.
Yeah.
I'll let someone else ask questions now.
Yeah, I think I'm pretty much done with the presentation. I think I just have like a thank you or maybe a summary or something, but so if anybody has any comments or anything.
I wanted to make a comment too, Tom. First of all, thanks for putting up these very interesting questions. I think under item 2 with the digital twin report, I want to come back to your introduction of your first lecture on Tuesday, where you compared it to weather reports. So I think the predictions you make could be compared to a weather report, as you said, right? And if we say it rains with 90% probability, then it doesn't mean it rains. It just means it rains with a high probability.
Right.
So I think this is a philosophical change we have to entertain, so that we say, okay, this is not a mathematical fact. This is a high probability prediction, and this is how it should be treated.
Yeah, I like this idea very much. We've actually, we've of course we've thought a lot about these questions. I didn't want to give what we had done, because I was hoping, I always wanted not to bias the situation, but what we've kind of discovered is that these physicians are already sort of doing Bayesian statistics in their head, right? They already have their priors based on everybody they've treated and everything they've studied and so forth. And then they bring in the individuals. So this is already kind of happening. It's just we're now trying to put, a firm base underneath it in this mathematical modeling. So I don't know. I'm hopeful that it is not completely divorced from reality, but we have to have that success story first. And so that's why that first low-hanging fruit is so important. We have to at least be not wrong with that first attempt. Yeah. Well, I'll go ahead and finish up here. It's 10:07. So the point is, if you want to design something that's useful for the individual patient, you got to worry about that individual patient's unique characteristics. Digital twins, are things that you can build now, and they're practical for predicting and recursively guiding interventions. We just have to figure out how we're going to deploy them in a practical manner. And then I would say this effort to mathematize oncology, and I don't need to say this to this group, but it's sort of inevitable, right? If you look at the history of science, once we mathematize something, we get pretty good at it pretty quickly. That's going to happen on oncology. It's already happening in cardiology. I don't know if I mentioned this the other day, but there's this. If you're not familiar with this company, HeartFlow, I'd encourage you to look it up. They take CTs, before and after contrast injection of the thorax right here, and they can use it by doing fluid mechanics on the measurements, on the CT measurements, to determine whether or not someone needs to have a stent placed. And that has replaced the need to do the cardiac cath, where you take that scope up through the femoral, up through the abdominal aorta, all the way up through the heart. It's an invasive procedure. Like 1 out of 1,000 patients bleeds out on the table from this. It's not without risk. But now they just do it with non-invasive imaging, and they can figure out if a patient needs to have a stent placed or not. And because it's built on it's built on Navier-Stokes, you can then actually predict where the stent needs to be placed. So you can do the optimal intervention and guide the surgeon. So it's a real success story in computational medicine. And that's the direction that we have to go. We have to be able to go. I think it will happen, right? Summary. So these things can be, we talked about mechanism-based modeling, where you take patient-specific information to calibrate the patient-specific, to make your model patient-specific, using that to drive digital twins that they can then have optimal control theory thrown at them to find the optimal intervention, and then you can continually update the system using data assimilation. So these are the people who do all the work. I just sit in the corner with them in the fetal position, worrying about how to pay for it all, and the people whose work I highlighted are pointed out here. Right. Okay. Well, thank you so much. If anybody has any questions at all, feel free to shoot me a note here. I'd love to talk more about it. And I'm happy to stick on here for another 10 or 11 minutes. Otherwise, have a great afternoon.
So thank you very much. This was a real firework of very interesting stuff. Really good.
Thank you.
Yeah, thanks for having the time to come to us and talk to us for 2 or maybe even 3 hours, taking everything together.
Well, thanks so much for the opportunity. I appreciate it.
Yeah, let's open the floor for questions. Yeah, then none immediate. So, Tom, I wanted to tell you about one idea we're having here at Fields. We want to write a book. And this book is supposed to collect success stories in mathematical modeling and ecology. So essentially what we were talking about. And I think we are at a point where some success stories are happening. So there's the stuff you do, and then with Guglielmo Lorenzi and David Hormuth, and I think you have a project on prostate cancer as well, right? In
That's
your
right.
group?
Yeah.
Guillermo
Lorenzo leads that. Yeah.
Yeah, I saw that the other day. And then Heiko Enderling, as you know, he did something on prostate treatments. So yeah, we want to collect these kind of success stories in a book.
Yeah, that's exciting.
And that would be useful because for the future, then people, if you ask, hey, what is this computational modeling good for? And then you can point to the book.
Right.
There it is.
Exactly. Right. Exactly. Right there. There's the Amazon link. I love it. Yeah.
So no, that's not my question. My question is, would you like to contribute?
Oh, well, of course, yes. It'd be an honor and a privilege for sure. Yes, absolutely. Yeah.
Yeah, I'm going to send you an invite, and then we can maybe put something of your work in there. So that would be nice.
Okay, cool. All right, great. Sounds wonderful.
Okay, further questions. Where are my chatty students? Yeah, but I'm sure they enjoyed it very much. This is wonderful stuff. So
Well,
then,
I hope so. If I
yeah.
put my email in the chat there, if anybody wants to follow up, I'm happy to talk about it.
Oh, nice. This is great. Okay. So then next week we have another visitor, which is Luigi Preziosi. Do you know Luigi, Tom?
I do. Yeah, sure. Yeah.
Yeah. Right.
It's
And
a
he
small
will.
community, right? There's not a lot.
So Luigi will talk about mechanics. So this is something we haven't touched much at all. I mean, you have touched it a bit,
It's
and
very small. Yeah.
very small. So he will give us more details about how to get mechanical forces, pressures, stresses, and all that into cancer modeling and tissues.
That's awesome.
Excellent. Thank you,
All right.
everybody.
Take care. Have a great one. Happy holidays.
Oh yeah, happy Thanksgiving. Absolutely.
Yeah. Thanks.